Sorry, Crab. I'm Dr. Chuck with CMC. I hope everybody's doing well today. Today, I'd like to continue with medical tutor. And I know last time we were talking about cranial nerves, but today I want to shift gears a little bit. I want to answer a medical student's question. A medical student asked me a very, very important question for the board exams and, especially USMLE. The student asked me about, the lab values of thyroid, how to answer thyroid question correctly with the lab values. So, to be more specific, with TSH, thyroid stimulating hormones, and T4, the thyroxines. So, I think this is a very important concept, and I guarantee you, you're gonna see so many questions on the USMLE or your board exam about, thyroid questions. So, I'm just gonna answer this question really quickly, in this video, and then the next med tutor video, we're gonna continue with the cranial nerves. So right off the bat, primary hyperthyroidism, what lab value you're gonna see? TSH, thyroid stimulating hormone, that's going to be very low. And the T4, the thyroxine, is going to be very high. That's primary hyperthyroidism. Now for the primary hypothyroidism, what are you going to see? What do you think? So the thyroid stimulating hormone, that's going to be very high, right? And the free hormones, the free thyroid hormones, the thyroxine, the T4, that's going to be so low, hypothyroidism, right? So right off the bat, this is the value that you're going to see in primary hyperthyroidism and primary hypothyroidism. And this is the basic value that you need to know in order to be able to answer some basic thyroid disease question, because, this is basic primary hyperthyroidism and primary hypothyroidism values. And of course, there's going to be some variables, in hyperthyroidism and hypothyroidism, there's so many subtypes. So you have to look at your question stems to see the patient's symptoms, to see, how tender the thyroid gland is and stuff like that. You have to see a lot of variables. And notice I just explained primary and primary hyper and hypothyroidism, right? What do I mean when I say primary? Primary hyperthyroidism means that the patient's giving out too much thyroid hormones because of the gland, the defects in the gland, right? And primary hypothyroidism means the patient's giving off too little thyroid hormone because of the gland, the defects in the gland. That's primary, right? In the questions, you might see secondary hyperthyroidism, secondary hypothyroidism too. That means that the defect is outside of the gland, right? Usually the pituitary, that's from the pituitary hormones. Maybe the patient has primary hyperthyroidism because maybe the patient has a pituitary adenoma, and the pituitary adenoma will stimulate TSH, thyroid stimulating hormone, to come out and stimulate your thyroid gland to give out thyroid hormone more and more and more. So we're going to talk about that later in this video, right? But just the basic value again, primary hyperthyroidism, TSH will be very low and T4 will be very high. And primary hypothyroidism, right? What are you going to see? TSH will be very high and the T4 will be very low. So these two values, the TSH, thyroid stimulating hormone, and the T4, the thyroxines, are the two variables that are very important for you to look at when you answer these thyroid disease questions. And as you know, I like to do these med tutor videos in the English language because English is a universal language of medical education, right? And I know you're tired of hearing me saying this, but medical education, I'm going to say it anyway, medical education takes very little brain. Medical education is not about how smart you are. It's more about repetition and being disciplined in your studies. Just sit there, go over your Qbanks, go over your concept again and again and again. And eventually, what you've learned, through repetition, through questions, that will bring what you've learned into your long-term memory. So keep on doing your Qbanks and keep on working your concepts. So in your board exam, something like USME, especially USME Step 2, you're gonna get a vignette about patient that has a thyroid disease, and then you're gonna see some lab values. You're gonna see the patient's had a blood test, and it's gonna show the patient's thyroid stimulating hormone TSH, and also it's gonna show the patient's T4, the thyroxine level. And they're gonna give you the patient some symptoms or maybe like the result of physical examination, and then they're gonna ask you how to treat the patient next. What's the next step in treatment? So that's like step 2, right? The next step in treatment. And the thing about that is you have to by looking at the values, right, the lab values, you have to determine if this patient is hyper or hypothyroidism. You know, what kind of thyroid disease does the patient have? That's the first step. Is the patient hyperthyroidism or hypothyroidism? And that you would look at the TSH and the T4. And do you have to memorize the normal value of T4 and TSH? Do you have to memorize it? The answer is no. So on your lab exam, on your board exam such as USMLE, you're going to be given a chart of all the normal lab values. In fact, in the USMLE, when you're doing on your computer, when you're answering questions on your computer, on the right, I think right below on your computer screen. It's been a while since I've taken, it's been once my test, but you click on the lab value on your computer when you're taking the test, and all the normal lab value will come up. So you click on that lab, on that table of the normal lab value, you check the normal TSH and the T4 value, and you compare that to the question stem. And then you can be able to figure out if this patient is hyper or hypothyroidism. It's pretty cool, right? You don't have to memorize the normal value. And after that, after you figure out if the patient's hyper or hypothyroidism, you can read the question stem again and then look at the clues that they give you, the physical exam or at the test, and then you can figure out what kind of thyroid the patient have, and then you can answer the next step in management that they will ask you. So your thyroid hormone is quite important, right? It's very important. The hormone that your thyroid gland gives out. The thyroid hormone is like kind of in charge of your growth, development, and it has an effect on every cell and every tissue in your body. Basically, your thyroid hormone controls the metabolism rate of your entire body. So that's very important, right? Your metabolism. Basically, hyperthyroidism, if your thyroid gland is giving out too much thyroid hormone, hyperthyroidism, what would happen? So your body would metabolism rate would increase. So what can we see in a patient that have hyperthyroidism, right? So your metabolism rate increase, what can you expect? Everything speeds up in your body, right? So you might see the patient might be thin because the metabolism rate is up. So you may see a thin patient, and you might see that the patient have diarrhea because the metabolism rate is up, and tachycardia, the heartbeat faster, everything speeds up in the body, and heat intolerance because you're burning so much calorie that you're feeling like hot all the time, right? And your skin might be moist. Mental state of the patient might feel anxious, be nervous all the time, anxiety, because the metabolism rate is up, the patient speeds up all the time, thinking is going to be like very the patient's going to be anxious all the time, stuff like that. So these are some of the stuff that we're going to see with hyperthyroidism. Basically all everything, every function of the patient's body is going to be speed up because the metabolism rate is up. Now hypothyroidism, your thyroid hormone, your thyroid gland is giving out too little thyroid hormone. So that's going to be little metabolism, right? Your metabolism rate is going to decrease. So everything in your body is going to be slower, right? And that's going to be opposite of hyperthyroidism, right? So now when the metabolism rate of the patient is lower, you might see the patient having weight increase, right? Weight increase, everything slower. The patient might be, instead of having diarrhea, the patient might have constipation. And the mental state, the patient might be depressed. The patient might have very dry skin, right, with decreased metabolism. And the patient might be cold intolerant because you're not burning as much calorie, right? So the patient's gonna be like that it's not giving out heat. The patient's gonna be like feeling cold all the time, and everything in the body is gonna be slow. So bradycardia, the heart of the patient, the heart will be slower too. So these are two opposite things, right? Opposite symptoms. Hyperthyroidism, everything in the body will be fast. Metabolism will be very fast. And hypothyroidism, thyroid glands giving out too little thyroid hormone, so everything in the body will be very slow. So how is the thyroid hormone released from the thyroid gland into our bloodstream? Because the thyroid hormone cannot be released by itself, right? It needs something to stimulate the gland, the thyroid gland, in order to release the thyroid hormones. What is the thing that will stimulate your thyroid gland to release the thyroid hormones? You've guessed it. Thyroid stimulating hormone, right? Thyroid stimulating hormone, TSH, is a hormone that will stimulate your thyroid gland to release the thyroid hormones, right? And TSH, thyroid stimulating hormone, where is that coming from? The TSH, the thyroid stimulating hormone, is coming from your pituitary gland, right? And the pituitary gland is actually called the master gland, or the master switch. So it's a master like endocrine gland, because it has the pituitary gland has an effect on other endocrine gland in your body. And if you forget what endocrine gland are, the endocrine gland are the gland that releases the hormone directly into your bloodstream. So like a signaling, release the hormone into your bloodstream and target like specific part of the body to do certain function. That's endocrine gland, right? To release the hormone directly into the bloodstream and cause so signaling for your body to like do something, right? So back to the pituitary gland. Pituitary gland is a master switch, as I said, and it has two main parts: the anterior part and the posterior part, right? And we're going to concentrate on the anterior pituitary, the front part of the pituitary gland, right? It has many cells, and each different cell secretes different hormones. And one of the cells in your anterior pituitary gland secretes a hormone called thyroid stimulating hormone, TSH. So this hormone will go into your bloodstream and it will come to your thyroid gland, and it's going to stimulate the thyroid gland, and it's going to say, hey, thyroid gland, it's time for you to release your thyroid hormone now. And that's the function of thyroid stimulating hormone. So it comes from your anterior pituitary into your bloodstream, targets your thyroid gland, and orders your thyroid gland to release the thyroid hormone. So your thyroid gland releasing your thyroid hormones, releasing a lot or releasing very little. It's under the control of thyroid stimulating hormone coming from your anterior pituitary, right? So your anterior pituitary release thyroid stimulating hormone, and that's going to control the amount of your thyroid hormone released from your thyroid gland. And the thyroid gland itself creates and stores your thyroid hormones. Basically T4, which is thyroxine, and your T3, right? Basically more T4 than T3. But your thyroid hormone needs one very important natural element to kind of create these hormones, and that's iodine, right? Iodine, and you need to obtain that from your diet in order for your thyroid to create your thyroid hormone. And you don't see this anymore, but in the past, in thyroid deficient in iodine deficient area, you might see the patient having goiter, the enlargement of your thyroid gland. That's goiter, right? And we call them simple goiter or endemic goiter if the patient has these enlargement, these goiters, because of deficiency in iodine. And usually you see this in like area where people lack iodine in their diet. You see the goiters, but nowadays you don't see them much anymore because we add iodine in some of our food, like salt and stuff like that. So you don't see these endemic goiter or simple goiter from iodine deficiency anymore. So our thyroid gland needs iodine to produce thyroid hormone. This is very important, and I'm gonna tell real quick actually the pathology of goiter for iodine deficient. Just real quick. So as I mentioned just now, remember that thyroid gland needs iodine in order to produce thyroid hormones, right? So imagine that you live in an area where you don't get iodine in your diet at all. So your thyroid gland will have trouble producing thyroid hormones, right? So in your body, your thyroid hormones will be quite low, and when your body sense that the thyroid hormone in the body is quite low, your pituitary will send thyroid stimulating hormone. So TSH will come and try and stimulate your thyroid gland to release thyroid hormones, right? That's simple physiology, right? But now your thyroid gland cannot produce thyroid hormone because you don't have iodine, you don't have that essential element to produce the thyroid hormone. So your pituitary will send TSH in large amount. Your pituitary will send TSH in large amount to try and stimulate the gland to produce thyroid hormones. But the gland cannot produce it because it needs iodine. You don't have the iodine. So what happens? The large amount of TSH will come and stimulate the gland, stimulate the gland, and it will stimulate the thyroid follicles. It will stimulate thyroid follicle a lot, and that will cause hyperplasia. Hyperplasia is reproduction of cells. So more cells, reproduction of cells, because of the stimulation of thyroid stimulating hormone to stimulate the follicles of the thyroid gland to multiply, to reproduce itself, and that's going to cause hyperplasia of the thyroid gland to make the thyroid gland enlarge. So the TSH will try and stimulate the thyroid gland to kind of spit out thyroid hormone, but the thyroid gland cannot produce any thyroid hormone because it doesn't have iodine, right? So what you end up with is with the thyroid stimulating hormone stimulating the thyroid follicles and causing hyperplasia. So that's going to cause simple goiter, and that's the pathology of goiter from iodine deficient. But in a normal working thyroid gland, the TSH, a thyroid stimulating hormone, will come from your anterior pituitary and stimulate the gland, right? And the normal working thyroid gland will release T4, T3 and T4 into your bloodstream, right? And T4, there's more T4 hormones than T3. In fact, when your thyroid gland releases the hormone T3 and T4, usually the T4 will convert into T3 in your tissue, right? T3 T3 hormones are like the more active metabolism enzyme than T4. So T3 is more like an active ingredient in making your metabolism rate quick, right? So usually, as I said, TSH will come stimulate your thyroid gland. Thyroid gland will release your thyroid hormone. Usually, both T3 and T4, but more T4 than T3. And in your tissue, the T4 will convert into T3, and that's going to regulate your metabolism rate. That's in normal working gland. So the amount of T4 or thyroxine or the free thyroid hormone in your blood kind of regulates your pituitary, your anterior pituitary, in releasing thyroid stimulating hormones, right? So like low T4 in your bloodstream, that's gonna regulate your anterior pituitary in releasing thyroid stimulating hormones to come and stimulate your thyroid gland in releasing more T4 hormones, right? But if your T4 hormones in your blood is very high, then the pituitary doesn't need to release the thyroid stimulating hormones because now your T4, your free thyroid hormone is so high, nothing needs to come and stimulate your thyroid gland to release more of the thyroid hormone. So the amount of T4 in the blood regulates if the anterior pituitary should release TSH more or not release TSH to come and stimulate the thyroid gland, right? So to recap again real quick, your anterior pituitary releases thyroid stimulating hormone TSH to come and stimulate your thyroid gland to release your thyroid hormone into the bloodstream, right? And if it's too much, if your thyroid gland releases a lot of thyroid hormone, then your pituitary doesn't need to release any more thyroid stimulating hormone because that's a lot of thyroid hormone in your body. So nothing needs to come and stimulate the gland to release more, right? And also the opposite, if in your blood there's very low thyroid hormones, then your pituitary will stimulate your pituitary will send out thyroid stimulating hormone to come to your thyroid gland to stimulate the thyroid gland to release more and more and more thyroid hormone. And this way of control is called the negative feedback, right? So low thyroid hormone in blood, pituitary sends out thyroid stimulating hormone to come stimulate the thyroid gland. And if too high thyroid hormones in the blood, pituitary stops sending out thyroid stimulating hormone to come and stimulate the gland because you don't need any more stimulation, because there's a lot of thyroid hormone in blood anyway. So negative feedback is a way our body keeps our thyroid hormone in the body to be the correct amount, and the balance between thyroid stimulating hormone and your thyroid hormone, especially T4. Now that you've understand this concept more, let's go back and look at the diagnosis again and look at the two lab values you need to diagnose thyroid diseases, the thyroid stimulating hormone, and also the T4, the thyroxine, right? So primary hyperthyroidism. What are you gonna see again? Remember primary hyperthyroidism. So hyperthyroidism, of course, you're gonna see T4 will be high, and thyroid stimulating hormone TSH should be low, right? Now you know why, because your thyroid gland is producing so much thyroid hormones, so the T4 will be high, but TSH should be low because why? That your THS, your body noticed that your in your blood there's so much T4, so the TSH should be low because there's no need for pituitary to send out thyroid stimulating hormone to come and stimulate your thyroid gland, because there's no need for stimulation because your body has so much thyroid hormone in the blood. So primary hyperthyroidism, T4 high, TSH low, and primary because there's a defect in your thyroid gland, and the gland is sending out too much thyroid hormone for some reason, and so the lab value again is T4 high, thyroid stimulating hormone low. And now primary hypothyroidism, right? What are you gonna see? Hypothyroidism. So you're gonna see low thyroid hormones, right? Low thyroid hormones, so low T4, but you're gonna see high thyroid stimulating hormone. You're gonna see high TSH. So what's going on in your body? Your body is saying that, oh, we have low T4, low thyroid hormones in the body. So what's gonna happen? Your pituitary is gonna send out thyroid stimulating hormone to come and try and stimulate your thyroid gland to increase the production of your thyroid hormones. So you're gonna see high TSH but low T4, right? And primary hypothyroidism. So the fact that your thyroid hormones are low, there's a defect in your thyroid gland, right? So this is the basic lab value that you need to know to try and be able to answer your thyroid questions. And also that's secondary hyperthyroidism and secondary hypothyroidism too. So secondary hyperthyroidism and secondary hypothyroidism, that means that that's a hyperthyroid and that's a hypothyroidism, but the defect occurs like outside of your thyroid gland, like the defect occurs somewhere else. So, and as an example, secondary hyperthyroidism, maybe the patient has a pituitary adenoma, right? The patient has a tumor on the pituitary gland, pressing on the cell that secretes thyroid stimulating hormones. So this tumor is going to cause an increase in production of thyroid stimulating hormone, right? So, and the thyroid stimulating hormone is going to come and stimulate your thyroid gland to release thyroid hormone, like unopposed. So what are you going to see in your lab result? On your lab sheet, you're going to see thyroid stimulating hormone very high and the T4 very high. So high TSH and high T4. That means something's pressing on the patient's pituitary gland to cause the release of TSH, and also the thyroid hormone T4 will be very high. So if you see high TSH and high T4, you better order the next step in management. You better order an MRI imaging study, MRI or CT of the patient's brain, and then you're gonna see that big pituitary adenoma pressing on pressing on the cell to release thyroid stimulating hormone. So that's secondary hyperthyroidism. Secondary hypothyroidism, that means the patient has hypothyroidism, but the defect is coming from outside of the thyroid gland. So again, usually has to do with something in the pituitary, right? Usually, maybe the patient had surgery near the pituitary area or somewhere near the pituitary in the brain, right? And that causes a defect in the cell that is releasing thyroid stimulating hormone. It's causing the defect that it doesn't release enough hormones, doesn't release enough TSH. So not releasing enough TSH, that means like nothing's coming to stimulate your thyroid gland to come and release the thyroid hormone to the rest of your body. So in the labs, you're gonna see the patient's lab, you're gonna see decrease TSH and also decrease T4, and that means secondary hypothyroidism. So once you figure out if the patient is hyperthyroidism or hypothyroidism, you have to look at the question stem, because there's so many subtypes of hyperthyroidism and hypothyroidism, right? And most of the questions on the board exam deals with hyperthyroidism. So I'm gonna give you a quick, just very quick, things about subtypes of hyperthyroidism that you have to look for in your in the question stem of your questions of your vignette. And of course, in these questions, you're gonna have to figure out that the patient has high T4 and low thyroid stimulating hormone. That's gonna be, bingo. You got primary hyperthyroidism. And then you have to look for, the keywords, and you have to look for like physical examinations that they give you on your vignette. So Graves' disease, what are you gonna see? Of course, you're gonna see high T4 and low thyroid stimulating hormone, right? But you might see something in the question stem about the patient's eye, lead lag, and the protrusion of the eyeballs. And you might see something with the skin, like a thickening of the skin, like below the knee, below the knee in the leg of the patient. And that should trigger you to think of Graves' disease, which is like an autoimmune disease. And next is that you should think, let me think, hypothyroidism, subacute thyroiditis, and that is usually the patient had a cold, like a virus infection that will cause the patient to have hyperthyroidism. And in a question stem, it might say that the patient just got over a viral infection. And examination, you might feel like a little bit tender in your thyroid gland. And usually you just treat the patient with aspirin or something like that to make the patient, to treat the pain of the gland and to treat the symptoms of the cold. Next would be silent thyroiditis. So basically, this is like an autoimmune immune process again, and basically everything, the physical examination will be normal, but the patient will have slightly hypothyroidism. And you might see like a keyword in your exam that the radioactive iodine reuptake, that's normal. And this is different than Graves' disease. Graves' disease, you see radioactive iodine will be elevated. So that's the difference that you can tell with the silent thyroiditis. And of course, next Will be synthetic thyroid hormone abuse. And in the question stem, you might see the patient who wants to be thin. They want to be thin. They take like exogenous thyroid medication because they want to be thin. And you might see the patient, shaking all the time, nervous, and when you feel the thyroid gland, you won't even feel the thyroid gland when you palpate the thyroid gland, because the thyroid gland will be it'll be like atrophy, because like the thyroid gland doesn't even have to like produce any more thyroid hormones anymore, because the patient's taking synthetic thyroid hormones to be thin. So the thyroid gland doesn't have to be used, so it doesn't have to produce thyroid gland because the patient's taking thyroid hormones. And so during the physical examination, when you feel the patient's thyroid gland, you won't feel it at all be atrophy, because as I said, the thyroid gland doesn't have to be used, doesn't have to produce your thyroid hormones, so it's going to be very small, and the patient's going to be very thin. And in the question stem, you're going to have a history about patient, wanting to be thin. And next, secondary hyperthyroidism. As I said, you're going to see TSH high and T4 high, and then you do an MRI of the brain, you're going to see that pituitary adenoma. So these are some of the questions you're going to see for your thyroid hyperthyroidism questions, and I hope you understand a little bit more the relationship about your T4 and the relationship with thyroid stimulating hormones, and how thyroid stimulating hormones regulates your thyroid release. And yeah, I just hope you guys got something back from this review. And as I said, in medical education, you often feel like, I don't want you guys to feel like you guys are alone. You're studying this. I felt alone a lot of time when I was studying these concepts when I was in school, and I don't want you guys to feel that way. So I just want you to know that I'm always there for you. If you need anything, you can message me through Facebook, and any topics you'd like me to go over, I'm happy to. And keep on doing your question, keep on doing your concept, especially your Qbanks. I'm Dr. Chuck with CMAC. Sorry,